Welcome back. Over the next 2 hours, we invite you to sit back, relax, and engage in a cognitive workshop during which your ways of thinking about implementing, evaluating, and analyzing the value of what you do in substance use prevention are brought to new levels and prepare you to move your needle a little closer towards extraordinary. I'd like to introduce 4 dynamic members of the National Prevention Science Coalition who will be leading you through this journey. Dr. Diana Fishbein is the Director of Translational Neuroprevention Research in the Frank Porter Graham Child Development Institute at the University of North Carolina. She is also professor in the Department of Human Development and Family Studies and the Director of the Program of Translational Research on Adversity and Neurodevelopment at the Pennsylvania State University. She holds multiple adjunct or affiliate positions with institutions including University of Maryland School of Medicine, Johns Hopkins University, University of California, Irvine, Georgetown University, and the National Institute on Drug Abuse Intramural Research Program. Dr. Fishbein studies use transdisciplinary methods and a developmental approach to understand interactions between neurobiological processes and environmental factors. She's published extensively and serves in an advisory capacity for federal and state government bodies, as well as several universities and organizations. She founded and directs the National Prevention Science Coalition for Improving Lives, a national organization dedicated to the transfer of knowledge from the basic sciences to practices in real-world settings and public health policies. Our next workshop presenter today will be Dr. William Aldridge. He is a senior implementation specialist and director of the Impact Center at Frank Porter Graham Child Development Institute within the University of North Carolina, Chapel Hill. The Impact Center, just so you know, focuses on the use of applied implementation science toward building capacity for stronger systems and communities. Dr. Aldridge is an adjunct professor at UNC Gilling School of Global Public Health, board member of the National Prevention Science Coalition, steering committee member of the Coalition for the Promotion of Behavioral Health, and affiliate faculty at Penn State's Edna Bennett Pierce Prevention Research Center. His work includes active implementation support and evaluation research on the implementation and scale-up of evidence-based prevention, well-being strategies in communities and state, regional, and national service systems. He is currently principal investigator on the implementation capacity for P projects in North Carolina and South Carolina. Our next workshop presenter will be Dr. Robin Jenkins. He is an associate director at the Impact Center at Frank Porter Graham Institute of Child Development. As a senior implementation scientist, Dr. Jenkins studies how to motivate and engage systems to implement reforms through rigorous implementation processes. As a community clinical psychologist, his applied and research experiences have involved children, youth, families, and communities. Earlier roles Dr. Jenkins has assumed include an appointment as the Chief Deputy Secretary of the North Carolina Department of Juvenile Justice at the North Carolina Department of Public Safety. Dr. Jenkins has served at multiple levels of policy influence, including 12 years on the North Carolina Governor's Crime Commission and 8 years on the Federal Advisory Committee on Juvenile Justice. And our final presenter today, who is also a board member of the National Prevention Science Coalition, is Dr. Max Crowley. Dr. Crowley is a prevention scientist investigating how to optimize investments in healthy development and well-being. This work sits at the intersection of social policy, prevention science, and public finance. His program of research is motivated by a desire to increase the use of cost-effective, evidence-based preventive strategies to improve the lives of children and families. Dr. Crowley seeks to not only understand the cost and benefits of prevention, but aim to better develop interventions and encourage them to be implemented widely. Dr. Crowley's research is funded by the National Institute on Drug Abuse, National Institute of Nursing Research, National Institute of Child Health and Human Development, National Institute on Aging and Substance Abuse and Mental Health Services Administration, as well as several foundations. Please welcome Dr. Fishbein, who is going to kick us off.
Hi, everyone. I'm excited to talk to you this afternoon about the extraordinary things that we can accomplish in the prevention space. I'm going to start with a quick introduction to the National Prevention Science Coalition to Improve Lives. We are a large professional organization of about 800 experts across a wide range of disciplines that are relevant to prevention science. Such an extraordinary body of knowledge, I know, yes, this is the theme today, has been amassed. But the prevention science strategies that have been generated by the field are chronically underutilized and underfunded. So we got together as a collective with the goal to bring science to life by embedding it both in systems and in our mindsets so that we can make a real difference in child development, in health and overall well-being. We work a lot at the level, but we also work with state legislators, and we do congressional briefings, and we write white papers and op-eds and fact sheets. And we basically distill the science so that it can be accessible to the legislative audiences that we work with. And most recently, we have launched a Congressional Prevention Policy Caucus on Capitol Hill, which gives prevention science a home on the Hill so that we have a hub of resources and experts and ongoing consultation with federal legislators to bring that work to them. So we are hosting this workshop in support of the HIDA communities and the ADAPT platform to supplement your knowledge and your know-how. Never before has the value of prevention science become so apparent to the public and to policymakers as it is right now in the midst of a pandemic. Most before this have not really understood what prevention science is or that there's even a science to it. But now, with the pandemic, and we all are witnessing the uneven impacts of the pandemic on underserved and marginalized populations, it has highlighted the need for proactive approaches to prevent underlying conditions that increase risk just to be infected, that worsen the damage from the infection, and that further exacerbate the existing disparities that we have in our society. But the value of prevention extends well beyond disease management. It's really about how to create conditions conducive to health development, to create conditions that are conducive to nurturing families and strong communities, and really a solid social fabric. I'm going to show you a public health parable that's going to frame the rest of my talk and that of others. And then we'll come back to this slide to get into the nitty-gritty. So I hope that came through for everybody. That upstream analogy describes primary prevention, which is a key concept in public health approaches. So by focusing on primary prevention, which was building the fence, the public health approach consists of population-wide efforts to prevent disease or harm. So you can see here in this picture, at the downstream phase, what we're really doing is triaging. We're being reactive. It's tertiary prevention. It's treatment, okay, which is absolutely necessary. There is no question about that, because we can't always prevent people from falling into the water. But what we're really doing here is chronic problem management as opposed to crisis prevention. So the focus down here is on the deep enders, those that we couldn't catch, those that we couldn't prevent from being exposed to factors that increase the likelihood of substance use disorders and other psychopathology. Further upstream, we can inoculate at-risk populations. So here we do have problems here. These are already kids that are at risk. Somebody said there's a bad echo, but I don't know what to do about it. So hopefully somebody can help me on the other end. So here is where we have strategies to modify individual behavior or the prevailing conditions that people are being exposed to that are increasing their risk. So we see conduct problems, we see early stages of drug use, we see risk for not graduating from high school or from dropping out of school. We use violence control measures. We address poor maternal health or the need for parenting supports and so forth. So we're already dealing with issues here, but we are focusing in a targeted way. Further upstream, we are promoting resilience. And so now we're getting a little bit more to the fence building aspect of it, but not quite yet. But here we want to systematically deliver programs or program components. We want to make people aware. We want to educate about what the risk factors are and how to avoid exposure in children and adolescents. We want to promote wide-scale adoption of programs. And interestingly, we also want to change mindsets in our communities so that we can enrich daily interactions with each other and with our young people. So, for example, we want to strengthen social competency and coping skills. And we want to look for solutions when problems rear their ugly heads. And we want to build supports into communities and systems. And at the fence building stage of things, here is where we're at the population level. Here is where public health measures work to normalize prevention. So it is here that we are actually addressing the fundamental social determinants of health. These are the conditions under which people grow and are born and grow and live and work and play. And so we're reducing exposures to the detrimental influences at the outset. This is the really extraordinary promise of prevention. So what is behind the science of prevention? Not to belabor it, but these are the things that prevention scientists engage in. Ultimately, what we want to do is disrupt pathways to negative outcomes, but we also want to improve. We want to promote the health and well-being of our citizens and especially our young people. So we look for risk factors, and we determine ways in which they can be reduced and how we can strengthen protective factors. We build prevention practices and programs and interventions. We study them to see what works and what doesn't, and for whom and why and under what circumstances. And we develop an evidence base for those practices. And then we also determine what the best practices are for implementation and scaling, which is what my partners in crime here are going to be talking about in a little bit. And then with respect to the fourth, we often forget that we need, in order to exert impacts where the rubber meets the road, we need to communicate that science to our end users, which are, community stakeholders and practitioners and clinicians and policymakers. Sorry, I'm reading what people are writing, and policymakers and so forth. So we need to determine what the optimal means are for disseminating that evidence. So what have we learned? Here's what we've learned. We have learned first and foremost that what the problems are that are underlying all high-risk behaviors is poor self-regulation. And so it's interesting and maybe fortuitous that when Nora Volkow spoke this morning, much of what we're talking about will overlap. We're both kind of in the neuroscience field. And so I'm not going to drill down as much, but I just want to put this into a prevention context as to why it's so important that we understand what it means that that individuals are not self-regulating well. So what neuroscience tells us is that the building blocks need to be there for brain regulatory systems to develop in a way that's healthy and normative by the age of 11. So it's very important because the brain is so experience dependent. It's absolutely essential that children are exposed to nurturing conditions in order to develop the brain systems that are responsible for scaffolding self-regulatory behaviors. This work, neuroscience, actually emphasizes the importance of nurturing caregivers and nurturing environments on brain development because it is so sensitive to everything that we experience. The brain responds to that even in adulthood, but especially in childhood when the brain and behavior is so malleable. And what we've also discovered is that there are particular brain systems or structures and connections in the brain that specifically support healthy attachment, socialization, adaptive learning, and self-regulation. These systems scaffold these abilities, and it's critical that they develop in a healthy way. What this research also shows us, however, is that ACEs, adverse childhood experiences, can produce many negative impacts on the brain. And those impacts that disrupt brain development can translate to problems with behavioral health. On the positive side of that same equation, however, which is very exciting, and Nora Volkow got into it a little bit this morning, is that well-timed, evidence-based strategies can actually enhance the way the brain grows. It can fuel it, it can nurture it. And if we can grow brains in a way that are healthy, then that portends really good outcomes for children throughout the rest of their lives. It can have an enduring impact on their developmental trajectory. So I just want to show you this figure because it demonstrates how targeted intervention can even change the adult brain, which is not nearly as plastic and malleable as the child's brain. But these are averaged images. So these are more than one people, and the images have been averaged to show you what happens prior to treatment for people with a spider phobia. So who doesn't have that, right? No, but these are people that really have a serious phobia. So they're put in a scanner, and when they're shown images of spiders, their parahippocampal gyrus lights up in a way that is abnormal, that is much more so than people who don't have a spider phobia. And then after given treatment, which in this case is cognitive behavioral therapy, which importantly is a staple in the substance use world, that it no longer lights up. So the parahippocampal gyrus right here is no longer lighting up when they view images of spiders. So their phobia has basically been extinguished. And so given that a child's brain is so much more malleable, we see that evidence-based prevention, if properly targeted, can actually reverse damage and improve overall functioning for the long haul. And certainly the earlier you intervene, the better. But it's never too late. All is not lost in adolescence. People think, well, adolescence, it's too late. Things are already entrenched. But no, in reality, adolescence is the most malleable period in life. It's remodeling. The brain is remodeling and becoming more efficient, and things are becoming more connected. And interestingly, neurobiologically, the brain doesn't fully coalesce and connect until you're almost 30 years old, which is why I'm always telling my children, you can't do that yet. Your brain isn't connected yet. But in all seriousness, if you see the orange part here in this brain, that is the prefrontal cortex, and it's becoming more focused and paying more attention to relevant stimuli and less attention to things that can be distracting. It's becoming more efficient. And the second thing that's happening is the prefrontal cortex is becoming more connected to lower centers. There's more communication with the limbic system. And what that translates to is that there's more cognitive control over emotional impulses. So there's tremendous opportunities to help change things during the course of adolescence. The next thing that we have learned, which relates to this, as I've already mentioned, is that adversity, stress, and trauma are often root causes. Here we have a depiction of roots in the figure that represent the fundamental problems, the environmental determinants of whether children are likely to experience ACEs. So these are root problems: domestic violence or community violence, poverty, discrimination, poor housing, poor nutrition, etc. So these are at the foundation of the problems with respect to ACEs, because if you have any of these or a combination of these risk factors, then you're more likely to experience those that are above it, which are represented by the leaves of the tree. So you're more likely to experience some of these ACEs as a result. And if we use upstream approaches, we can deal with these roots of the problem, and that will lead to fewer children experiencing and reporting the leaves, in other words, the ACEs. And just as a really profoundly impactful slide for you to see what happens when children experience ACEs is that when they have no maltreatment, these are aggregated pictures as well, it's more than one child, no maltreatment, you see the connections between nodes of the brain that indicate that there's good self-regulation, there's rich communication and connectivity, and so they're much less likely to be dysregulated in their behavior and emotion. But the maltreated children have very few connections, suggesting that they're not enriched with the circuitry that scaffolds self-regulation of emotional and emotional responses and behavior. So what else have we learned? We have learned, sorry about that, that there are evidence-based interventions that have been developed from the prenatal period through adolescence and emerging adulthood. And this is a wonderful slide from SAMHSA that shows genres. So these aren't specific programs, but these are genres of programs from prior to conception all the way through young adulthood. So within each of these buckets are numerous programs that have been shown to work to basically disrupt causal processes that lead to risky behaviors. And the potential lifetime benefits of any of these programs certainly are greatest with early intervention, but like I just said, it's never too late. And most prevent multiple problems, even chronic disease, even if it's not an outcome that is targeted by the intervention. For instance, violence prevention strategies have been shown to reduce chronic disease in adulthood. So multiple problems, it's best if they're comprehensive. And as we know now very well, it is best if they are trauma informed. And so what does that mean? Like if we have all these interventions and many of you are actually implementing them in the field, what does that mean for measuring whether they're working or not in your particular sites. How do we measure what we cannot see? And this is an ongoing issue for the field of prevention science, obviously. There are many ways, because we're looking at the things that precede the behavior before the onset of substance use and substance use disorder. So these are all the different levels, and I just have some examples here: individual level, relationship, community, systems, and policy level. And for each of these factors, there are instruments that enable us to measure ways any given intervention is working to disrupt these pathways to substance use and disorders. You can use self-report, you can use interviews, you can use biomarkers, social network analyses, cost-benefit analyses. You can determine where investments are being made by community organizations or governing bodies. You can look at policy change. So there are instruments for all of these different measures. Sorry, for all of these different factors. So next to final, we also know, we have learned that disadvantaged children are more likely to be impacted by good, solid interventions because they're falling behind due to the multiple ACEs that they often experience. Interestingly, we know that an effective intervention can actually potentially break the cycle of intergenerational struggles. And there's also growing evidence for the impacts of systematic delivery of preventive interventions and policies and programs to actually reduce the fundamental inequalities in our society. Sorry. And then finally, we know that implementation must be rigorous and sustainable. So even with the best evidence and the best practices, none of this matters if we don't have high quality implementation. When we don't, prevention gets a bad name and then funds are withdrawn, even when we know that prevention can work when it's done right. So I am going to now introduce my colleague. We're going to get into how all of this is done, what it looks like, where the rubber meets the road. I'm going to introduce Will Aldridge. He is my close colleague at FPG. He's a member of our coalition board. He is the most knowledgeable fellow I know in the field of implementation science, and he is just a great guy all around. So Will, take it away.
Well, thank you so much, Denny. I really appreciate that overview of prevention and your introduction. Good afternoon to many of you who are like me on the East Coast, and certainly want to say good morning to our friends and colleagues on the West Coast. My name is Will Aldridge again, and I'm going to be talking about our next piece of the puzzle towards the extraordinary, the implementation and scaling piece. Just want to acknowledge that a lot of the concepts that I'll be talking about, we use in our daily work at the Impact Center at Frank Porter Graham Child Development Institute. So just want to start with a thought exercise for you. I'm going to go through a few different real evidence-based interventions or programs from real data. And I want you to consider and think through which do you prefer, Program A or Program B? So the first is an employment program in adult mental health. Program A, what we're looking at here for the outcome is the percent employed after the participant goes through this program. Program A, you can see somewhere around 43% of participants are employed after the program, and Program B, around 93%. Let's look at certainly a relevant one today, an adult substance abuse treatment program. So we're looking at percent clean urine screens here. Program A participants, you see around 29%. And then for those participating in Program B, just over 80%. And lastly, a school behavioral health program. The outcome of interest here is percent reduction in aggression. So again, be thinking about your family, your children. Those who are participating in Program A were right around 20% reduction in aggression in the school. Program B, we are around 55%. So hopefully you've had a little bit of time in thinking about what program you want to involve your family in. But here is the kicker. In these charts, Program A and Program B are actually the same program. These are evidence-based interventions, whether they are supported employment, which is SE, dialectical behavioral therapy was the substance abuse treatment program that was used, and PAS, the promoting alternative thinking strategies. What differentiated and what we were referring to here with A and B is a low fidelity versus a high fidelity implementation of that program or that intervention. So really one of the first takeaways here is that fidelity is predicting outcomes. And by fidelity, we don't mean reading from the manual or going through a script. What we're really talking about is core ingredients of that program, active components, and ensuring that they are reaching the participant of the program. This is, pervasive in many ways as we look at implementation and scaling. This is data from a rollout of functional family therapy in the state of Washington that occurred earlier in the 2000s, was published earlier in the 2000s. What you're looking at here, the numbers through 25 in these bar charts are actually therapists. These are their caseloads that you see in the bar charts. And the percent of their caseloads that are re-entering the juvenile justice system are coming back into contact. So recidivism. If we look at the bottom, we see a control group bar, and that control group had about 22% recidivism. Well, we can take a cut of these caseloads and these therapists where this dotted line is. And the interesting thing is for those therapists 1 through 12 above the cut line there, those who are therapists that were meeting fidelity criteria, and their recidivism rate was about 13%, which is great. That's better than the control. If we look below the dotted line, these are therapists that were not consistently meeting fidelity criteria for delivery of this intervention. And the recidivism rate was 28%, was actually higher than the control group. And finally, a really interesting meta-analysis that was done in the early 2000s around comprehensive school reforms. In these, when they were trialed in research, of course, every teacher in the trial was trained and provided continual support. But what these authors found is they looked at the rollout of these 4 different comprehensive school reforms across 5 years. Was that in years 1 through 3, fewer than 50% of the teachers were actually getting trained, the intended teachers. And then of those, only 25% or less were getting continual support with the use or implementation of that reform effort. In years 4 and 5, they found that fewer than 10% of schools were using those comprehensive school reforms as intended. And it is very likely that because of that, the vast majority of students did not benefit. This is a program that rolled out nationally, over 8,000 schools in this meta-analysis that were looked at, and about $2 billion that were spent in trying to get these comprehensive school reforms in place. So one thing that we have really learned here is that our traditional methods of implementing generally are not sufficient. They don't work. In fact, when we look across the literature, we find that things like diffusion, publishing things in peer-reviewed journals alone, or disseminating it through training manuals and materials, training alone, passing laws or mandates, requirements, even providing financial incentives. When these strategies are used alone, they are typically resulting in around 5 to 15% uptake of these interventions or use of these interventions as intended. They are necessary pieces, but they are not sufficient. So what we have here is really a story of typically an implementing site, maybe a program purveyor that's bringing materials and training, and a funder getting together and expecting child, youth, family outcomes down the road. But this has been a bit of a black box, almost expecting that this is going to happen by magic. Why is that? Why does it take a miracle? These are some of our favorite quotes about system and organizational practices. The first one, all organizations are designed intentionally or unwittingly to achieve precisely the results they get, right? So if we want different outcomes, we need to change the system, change the organization. Same thing in these two as well, demonstrating that The systems are there, and they have their own inertia that even with the most evidence-based program or intervention, those systems or organizations are likely to eat it alive over time. So how do we move from the ordinary, if that's how we might define ordinary implementation and scaling, to the extraordinary? Well, implementation science is all about finding a better way. So real quick, what we mean by implementation is the following. This is one of my favorite definitions of implementation. First off, it is a process. It is not an event. It does not happen overnight, but it is a process. And I've highlighted here the key parts of this definition that resonate with me. They involve multiple decisions, actions, and corrections, right? So this is a learning process that we have to engage in, that we're trying to change structures and conditions so that these new innovative evidence-based programs can have their intended effect. What we don't mean, which we often have to kind of make sure we're checking with folks, we do not use the word implementation as meaning to use or to deliver. We often will say you're delivering a program in that scenario. But what we mean by implementation is we mean supporting the delivery or supporting the use of. And so the target area is more upstream, even in the organizational process or system process, and thinking about what the conditions are there to ensure those who are responsible for delivering a program, practice, or intervention have the support they need to do that well. And we interviewed a stakeholder a couple of years ago who really said, you know, implementation science is really most akin to the field of engineering. It's about making things work and solving challenges in context. So we've got an intended outcome. We may be trying to get this boat across a river or trying to cross a river. We have in front of us pieces, parts, tools, and maybe a team around us, but we have to figure out, how do we put those parts together using the tools we have and the team that we can bring to the table? And we may put that boat in the river to try to cross it first, and it may just immediately sink. So we pull it out, we tinker, we re-engineer it, we put it in, and maybe we get halfway across before it starts to take on water. But eventually, if we learn and we do this process enough, we're going to figure out how to get that boat across the water. That's what implementation is a lot alike. And going back to that black box, what are the pieces that are around us that we have to begin to put together? In unpacking the black box, this is how we have been addressing this and helping folks think about it. And I'm going to go through each piece of this theory of change in part. The first part is the co-creation partners. You may remember from that ordinary scenario, we have funders, we have the implementing site and a purveyor. But really, co-creation involves bringing in other folks as well, support systems or other intermediaries that provide support both at state and local levels. Community members, those who are actively participating in or consuming that program or practice or being affected by a policy. And the original intervention developers or those who may be ongoing evaluating it, because we need to understand those core components, how to protect them if that's what's driving outcomes, and where we are able to make adaptations to local context, preference, needs, values, so that we can ensure that the program reflects the context in which we're implementing it. And one of the things that this co-creation process enables, it doesn't guarantee it, but it enables it, is a real attention to equity and inclusion throughout the program or the process of scaling. It gives us a chance, if we really think about it and are intentional, to disaggregate outcome data, to look at disparities, identify root causes, and then to involve those who are being affected disproportionately in co-designing both program, which is hanging out over there above the picture on the right, and implementation strategies. Getting them involved actively in putting those implementation strategies into place, and then continuing to work in partnership together to monitor and improve outcomes and ensure that disparities and inequities are reduced over time. So that's co-creation. Let's talk about the capacity and the performance piece. And you may be saying, Will, this is great and fine, but what in the world are water faucets and water flowing through it showing up here? What's the story? Well, you know, we think of capacity as like the pipes, and performance is the water flowing through the pipes. And you can have one, but not the other. In fact, that's often been the case in a lot of our human service systems. This is an image, of course, where there's a lot of performance that's probably happened, a lot of water, but there's no capacity to get it where it needs to go, to carry it on, and therefore it just seeps into the ground. It pools up, some of it evaporates. Here's one where there's a little bit of capacity and a little bit of performance, not very good directionality or aim, and certainly it's not getting in a good place. This image is, I like to say, quite often reflective of a lot of our public service systems where there's a huge amount of performance flowing and expected, but oftentimes the capacity is almost bursting at the seams. But what we're after for good implementation, extraordinary implementation, is something like this, is nice, solid piping, carrying that water intentionally in good flow where it needs to go, where we're trying to get it. So what are the pieces of capacity for implementation and scale up? Well, we think of 4, the first being leadership in team structures whose performance is leading and supporting implementation. Workforce development systems that are developing competent and confident practitioners or teachers or frontline deliverers, whatever you may call them in your context. Quality and outcome monitoring systems, both for gathering, analyzing, and reporting data, as well as using that data for ongoing learning and improvement, which, as we discussed before, is essential to the implementation process if it's to be successful. And lastly, media and networking systems. This is the idea that programs and practices are likely to only reach a certain segment of the population. Therefore, we need to be thinking about things like public health communications campaigns that begin to mobilize knowledge, techniques, strategies, and model them at larger levels through media, through other channels, so that we can begin to create readiness and begin to put calls to action into place that get families, children, youth the amount of support that they need and begin to prepare them to seek that. Next is the optimization of implementation and scale up. I love this cartoon, Far Side cartoon. It's a great example of having capacity. So these gentlemen have the plane around them. They are performing, so it's implied that hopefully the plane is up in the air. They are communicating as a team. They have a data dashboard in front of them, but they are saying, if you can see it, one turns to the next and says, say, what's a mountain doing way up here in the cloud bank? Well, that's a good sign, perhaps, that either their data system or dashboard is not functioning well, or they're not paying attention to it because they are way too low and likely getting ready to run into the side of a mountain. So we need to optimize our performance for sure. What does that mean in terms of implementation? We've talked a little bit about one of the cornerstones, if not the cornerstone, which is good fidelity. And there are multiple types of fidelity. I won't go through them here, but things like adherence, quality, engagement, and dosage. But there are a number of other implementation outcomes that we can use. And want to thank Nola Proctor, who really developed this for the field of implementation science, but looking at things like adoption and feasibility and appropriateness. And to me, many of these begin to get into how we do both fidelity and have good flexibility in terms of designing and creating good optimized implementation and scaling processes. And just to note that Max Crowley, one of my colleagues on the panel, will be talking in particular about some of the cost things as an implementation outcome in just a little bit. So going back to our integrated theory of change, the last piece of this is desired population level outcomes. And of course, this is why we're here. This is what Denny was talking about in terms of really changing the nature of outcomes at population level for children, for families, for communities. And when we think about that, of course, very much as Denny presented a bit earlier, we are trying to increase indicators related to advantageous child and youth experiences and development and decrease adverse child and youth experiences and development, which can be measured in many different ways. So that's great. That's a wonderful theory of change, Will. But do we have any indication that it works like this? Well, this is some of our data from our efforts in North Carolina to implement and scale up, to help implement and scale up the Triple P Positive Parenting Program, which is one of those parenting and skills training programs you saw on Denny's slide with all the genres, if you will. Well, we actually went into 2 counties, just an evaluation. There's no control, so I want to be accurate in how I represent this, but we got practitioners to give us some information about adherence to the protocols, the intended adherence, which of course is one aspect of fidelity that we just went through a minute ago. And what was predicting practitioner adherence? Well, it was this infrastructure. It was things like workforce development systems and quality and outcome monitoring systems. Did the practitioner's organization have those infrastructure pieces in place? And what was predicting whether those infrastructure pieces were in place? It was the leadership and teaming structures, management structures for implementation in those same organizations. And these were moderate to large effect sizes. So the idea there is you could walk into different provider organizations and see with your own naked eye the differences that these associations make, where the practices, the infrastructure is in place and the teaming structures that are enabling that, and how that is impacting practitioners' fidelity or adherence. I've got a link here as well that you can read a little bit more about this evaluation and see some videos on your own time. I also want to use the opportunity to reflect that many of the pieces that I've just covered in this theory of change are integrated into a recent consensus study report from the National Academies on fostering mental, emotional, and behavioral well-being in children and youth. Very much in a recent update to the field in prevention science that was funded by the Centers for Disease and Control and NIH, as well as SAMHSA. This is the link, and I believe that there is a highlight report included in your resources. So if you take a look at that, and in fact, want some more information on this theory of change I've gone over, part 3 of this report is all about it. So you can read a bit more about all the pieces and parts and what we know about good implementation when we're trying to scale up prevention. The last thing I'll leave you with is this concept, and to provide a segue to my colleague, Robin Jenkins, which is that all of that has to happen, but it doesn't happen at a flat level. It's typically going on in multi-layer systems when we're working in states and communities. There are state agencies and partners who may be providing funding and governing structures, administrative structures. There may be support systems that are enabling and supporting those who are at the front lines delivering these programs, interventions, practices directly to families. And so these are a couple of images, one on the left from our North Carolina PPP work, and the one on the right, a simplified one, just to get across these different layers. And the last thought I'll leave you with as I introduce my colleague is, where are you? Because where you are in these systems will begin to help you identify what's my role in this work and what are the steps I might need to take to enable that role. So without further ado, I want to thank you for listening to my talk. And I want to turn it over to Robin Jenkins, my colleague at the Impact Center at Frank Porter Graham. Robin is a wonderful colleague that has spent many years in state government, working with local nonprofits, and working at many levels across the country, doing helping assist federal projects have their intended impact. And he's going to really try to take these conceptual pieces I've gone through with a little bit of data and begin to get you thinking about how do you make this real where you are and where you're working. So I'm going to turn it over to Robin.
Thank you, Will. Great presentation. Want to also thank the fantastic leadership of ONDCP and Amber, Laura, and the team that helped build the sort of technical backbone for this. It's been a great day, and I've really enjoyed all the presenters and all the knowledge that's been shared. So I just really want to send out a moment of appreciation for that. Will's done a fantastic job, really, he always does, of helping us understand how implementation science leads us to effective strategies and approaches that enable capacity building and ultimately performance towards evidence-based interventions and scaling. I want to spend a few moments sort of putting that wisdom into some themes, sort of key take-home points about the how we do it, in order to maybe think about achieving them in a practical, beneficial way. And there's sort of 3 overarching themes in this conversation. One is that this work has to be approached with an open systems framing or an open systems lens. You've seen from the presentations this morning and what Will has talked about that virtually all of these support systems engage cross-system partners, co-creation partners, multiple stakeholders at multiple levels in the system. So this open systems frame and perspective is critical to understand and also to be able to navigate. The second theme I want to really hit home is this concept of leadership. Leadership is a overly simple idea in implementation, and it often starts well, but doesn't always end well. And I'm going to point the finger at myself when I talk about leadership because I've made many of these same mistakes as I've come along in my career. And I want to just let folks who are in leadership roles know that while I'm speaking to some of the leadership mistakes that people often make, it's from my own experience and also what I've learned in the implementation science literature and not pointing any particular fingers. And the third theme is really about implementing implementation. It's this idea of, well, let's see, this is going to go, okay. Yep, systems level, here you go. Leadership, and then this idea of implementing implementation, that there's this sort of meta awareness, if you will, of understanding how implementation and prevention systems work interactively and together. And to do it well, you really need leadership and awareness across the prevention system, both vertically and horizontally, to manage it all. So these points: successful implementation, system level focus, leadership is foundational. Let's go slide deck. Part of that implementation awareness around implementing implementation includes this idea that sustainability is best designed from the outset. So when you're thinking about cross-system collaboration integration, sustainability is built in. And really want to highlight something that Will and some of our earlier presenters have said, that sustainment and sustainability as concepts in prevention interventions across the system must take into account that cultural, local context, as well as the political context, in order to be effective. Without that context and the interactions and awareness of that context with your strategies and the design work and the way that you carry out implementation, there are big pitfalls coming ahead. Want to also emphasize something that Will mentioned, but is often left behind in our active implementation support work. Implementation support really means developing implementation infrastructure. These are the sort of guardrails, the team structures, the leadership processes and procedures, the decision-making and support systems, the QI, QA data systems, the plan, do, study, act cycles that go into it, and all of the mechanisms and strategies that get built into what it takes to effectively support the program. So I just want to reiterate this concept that Will talked about, which when we're talking about doing implementation, we're really talking about that creation of that capacity to fully support the work. And when you do that well, good things happen along the way. Okay. Making implementation happen in the local context, you say, well, what can go wrong if we've got all this capacity and performance and we sort of have the cookbook, the code book for how to do this? Wouldn't it be fairly simple to, get a grant, go out and build a plan, do a landscape or a needs assessment analysis, put together an action plan, and then go do that work as kind of a project-based strategy? Well, the answer is no. There are a lot of places where that can go wrong, and implementation science has shown us a lot, much of it having to do with not tending to readiness in the system, readiness in the workforce, readiness in the organization capacities, and also not tending to the readiness in the prevention system to fully support what you're taking on. So here you see some examples of where, things can go wrong. A couple more examples of this. Well, things not being well implemented by practitioners. You don't have confident, well-trained people doing the work. You might not have people who can reinforce the work in terms of their coaches, their skill development. There may be insufficient data systems or quality management systems that are missing or insufficient for the task. And there may be, in fact, no plans for sustainment and sustainability. People are all in on the front end. They're doing great program development work, but in fact, they're not planning for the longer view. These are common implementation problems that show up on the front end of implementation, and they're often problems with poor planning. So I wanted to hit home a couple of things that we built into this presentation to reinforce. Implementation is messy. It's really hard. You're dealing with wicked problems, complex problems in open systems. One of the most common things that happen, I do a lot of work in child welfare, substance abuse, and juvenile justice. And one of the most common problems that we find are that people sort of forget that even though you're tasked with delivering a policy, practice, or program as an innovation, you often have to rely, let's talk about child welfare, for example. Well, you have to rely on the juvenile justice system because the judges are sending children back and forth. You have to rely on the behavioral health system for treatment. You have to rely on the education system for both behavioral and emotional support in the schools and educational outcomes. You have to rely on local community supports for foster care or visitation and respite families. So you're really working with a number of collaborators and stakeholders who really need to be involved in the design and delivery of your prevention system. So it's messy. It takes a long time. Next point about this is that implementation in any context can take as much as 3 to 5 years in a high functioning organization. And as Will pointed out, sometimes it can take more than 15 years, sometimes not done well at all. And often implementation collaborations fail to account for the power and privilege or the equity and role issues that some of our presenters have already talked about. I know that people listening can name way more than I can the number of times a great grant idea came into a community, an organization went for it, wrote a great proposal, went out and did it, and really didn't take the time to bring the community to the table. This whole notion of nothing about us without us, this idea of making sure that those that are being impacted by the work have a voice in the work, because it's that context that really matters. All right, a couple of other points. Most often implementation begins with a deliberate focus, strong leadership. I've been in a number of places where there's a great kickoff. They've organized the work, they've got a great plan, they put together an implementation team, but failures often stem from insufficient ongoing attention of that leadership to follow through with multiple agency and system levels. There's often a breakdown in how that leadership checks in with the work, reviews data from the work, helps manage implementation team problems, barriers, crisis, turnover, and so forth. So that leadership is a really special key ingredient, sort of a secret sauce in implementation. And it's not just authority-driven leadership, but it's also informal, something that I'd like to talk about, sort of leading without authority. And most importantly, leadership and implementation, they're like muscles. You gotta exercise them regularly. You have to have a plan. You have to show self-discipline. You have to exercise it. And implementation and capacity building for the performance that Will outlined really means that using the rigorous science and data collection strategies have to happen with vision and commitment to the goals. This means leading both with and without authority and making that happen at all levels of the prevention system. It's worth noting, too, that a lot of the literature around effective implementation, especially in community environments and innovations that are designed to scale, really perform well, if not better, when they have active TA or external facilitated support for implementation. And there are a lot of reasons for that we don't have time to get into today. But many of the common, like communities that care and prosper, collective action, collective impact, all of those use facilitated and TA approaches to building implementation capacity, and there's a reason for that. All right, so let's talk about systems thinking for a minute. Designing for scalability and sustainability, we really make outcomes happen when we attend to that full prevention system. Will alluded to it on the next to the last slide, which are these sort of 3 levels. And when you do this well, it enables the full infrastructure to be transparent, and people know where the linkages are for policy, finance, using data, building responses to breaking down implementation barriers and solving implementation challenges. So when you do that well, you have the resources both vertically and horizontally. These prevention systems, by the way, can be mirrored at local levels in addition to state or federal systems. And so having an awareness of what these prevention systems look like, how they're governed, what the policy flows are like, what the regulatory requirements are, and then building implementation leadership to design for those levels, really critical. That cultivates the feedback loops needed to make sure that communities, agencies, and intermediaries involved are paying attention to the policies that need to be attended to, and also stress ongoing awareness of each level in the system. One of the big take-home points about all this is that when, by the way, Rohit Ramaswamy and his colleagues that took the interactive system framework that the CDC embraces, which really at this level uses the dissemination or the translation function to get into the prevention system. What Rohit and his colleagues did was remove the translation that's out there, but really focused on the governance, the policy, how the system gets sort of, again, the guardrails or the framework for making policy resources flow into the support and the delivery system. And what they sort of taught us is that this idea that the connections matter. You really have to pay attention to the the context, the intervention itself, making sure that you know what you're doing and that you're delivering it well with fidelity and all the things that Will mentioned, but also the implementation system, the whole prevention system, and where it needs to be nested. And so this is just a definition of those levels that Rohit and his colleagues meant. The delivery system are actually those people delivering the service, support system, those that are providing all the resources, technical assistance, and the functions that I mentioned, as well as the higher level, which is the governance structure, the policymakers and the administrators. It's also important to understand that when you articulate the system in both the context and infrastructure, this sort of awareness, leadership, and design with co-creation partners is key to aligning strategies, making sure that your implementation plans take into account all these levels. Too often people go out and deliver a great program, but they don't really spend enough time developing coalition or strategies across the support system or the policymaking system. So when it comes time to talk about sustainability or ongoing policy issues or sharing data, maybe breaking down data sharing barriers and so forth, then there's a long delay in solving MOAs or RFPs or other agreements that need to happen across this prevention system to make those things go well. But when you see that this is coming and that you design from the outset, you get optimal interactions between the different layers of the prevention system. Very critical to do that. So a quick thought question, this is rhetorical. How many have been part of implementing some new policy or program or practice where there was a great, inspirational leadership, people came out, messaged what was going on, great vision, maybe even been a strong kickoff, lots of media coverage, only to see it be delegated to a project team or a project group or a task force. The leadership moves on appropriately so. They've got a million other priorities, but the work became diluted because there was sort of a lack of momentum. Things kind of fizzled out. Other priorities, initiatives jumped up. And I can tell you, I just had this conversation yesterday with a juvenile justice jurisdiction in part of the country where they did extraordinary leadership development, a strategic plan, set priorities, and then they came back in the next quarter, 3.5 months later, and some of the implementation team sat around the table and said, why did we choose this as priorities? They're not priorities anymore. Well, the very fact that they're asking that question is an indicator, a diagnostic indicator that leadership had been sort of out of touch in terms of the data they were receiving, the feedback, relative to the criticality of those priorities and the work that was coming out of building the implementation infrastructure to serve those priorities. So that's just an example of what happens when leadership sort of checks out. To be clear, leadership is really important, and it happens in multiple layers in the prevention system and also multiple layers in the agency that's delivering the innovation, whether it's a policy, practice, or program. This is a slide that came from the World Health Organization, and it really depicts this idea of adaptive leadership versus using technical solutions for everyday challenges. And the notion is that a lot of leadership is by definition authority-driven. You get people appointed, you get people elected, you get policy or administrative folks who rise because of their wonderful skills in organizations. And so they're given authority to distribute resources and make important decisions. But often those skills are not sufficient for solving complex open system problems that we describe in these sort of wicked system problems. What we're trying to do is illustrate that this adaptive leadership, being able to understand and use adaptive strategies for building the right kind of team structures, to do the right kind of problem solving, to test the right kind of strategies in your implementation environment really matters. Because if what you traditionally do to implement is to load up a project team and then say, go do it, typically your project team will use their historical project management strategies to make that work happen and won't have the leadership support or the full prevention system support to bring in what needs to be done when these complex adaptive problems surface. So this is what I talk about when we talk about leading with and without authority. There are many people in your organizations or your coalitions or in your communities that are natural leaders. They have practice experience, lived experience, cultural experience, who can bring extraordinary wisdom to the work of implementation. And they are great stakeholders in not only designing the work, but in responding and supporting to the work and helping lift up and support the work should you run into future problems. This natural authority and this natural leadership is a big part, again, of the secret sauce of leadership that is often not talked about in sort of the implementation literature that you sometimes read. And this is what I meant by making it practical, making sure that you've got the right people in the conversation. Systems often delegate without the true commitment to create those feedback loops using data, qualitative, quantitative, reflective practices, building in management and administrative agendas where people take time to really check in and say, what's working well? What can we do differently? Not just talking about the EBI or the program, but talking about our implementation infrastructure. Do we have the right teams in place? Do we have the right people on those teams? Are those roles appropriately resourced? Who else do we need that has the experience to do this work well? And how do we make sure that we're checking in and using data to answer those questions in a persistent and reliable way? This next slide sort of illustrates a classic thing that we use in our professional development. I'm not going to spend a whole lot of time on it, but this is a screenshot from a table that Cotterman uses in pointing out the difference between managing and leading work. And in implementation, we need both. The management is a directive style. It's more of a technical approach, organizing and staffing and delegating responsibility, setting timeframes and that sort of thing. Leadership, on the other hand, is inspirational. It inspires people. It influences change. And what we try to do is get implementation sites and folks who are supporting implementation to pay attention to this whole constellation of characteristics around establishing vision, mobilizing inspiration around the human development side of it, executing that vision, and then ensuring the outcomes happen. Too often, implementation leadership does this on the front end and then leaves it to the project team or the local coalition to figure out the technical stuff and doesn't follow back through. And this is one of the big pitfalls of effective implementation. All right, so the last sort of key point here is paying attention to the big picture. Guiding implementation at multiple levels. And this is where we really step up and talk about moving implementation from the ordinary to the extraordinary. Here's this idea that implementation happens at multiple levels. This capacity and performance that Will talked about, well, your implementation is always local. Capacity is always local, but it takes supporting that capacity. Sometimes you have to build capacity to create capacity. And so these four levels really speak to program level implementation, which is the evidence-based innovation, the coalition or the partnership capacity and integration you need to pay attention to, the implementation strategies across the prevention system that links those connections that I mentioned, that connective tissue between context, the intervention, and the implementation infrastructure. But lastly, and perhaps most importantly, is this meta level, this implementation, being able to step back on the balcony and focus on how are we doing relative to the full array of the prevention system across these levels in terms of the co-creation partners, the leadership and teaming structures, the workforce development strategies, the development of data management and decision support systems, and of course the media, communications, and networking, which was the fourth capacity that Will mentioned. This meta awareness and meta leadership level is a skill that most of us don't have when we come along in our public service agencies, and it comes through ongoing integration of implementation efforts and ongoing training such as this, and coach and facilitated support through TA and intermediary organizations. It's easy to be distracted by staying at the program level. It's often most satisfying. Many of us get trained in program evaluation and theories of change and logic models and all that sort of stuff. But you must be able to step back and get on the balcony and think about these multiple layers and then lead through this open systems perspective with that integrated approach in mind. Just a quick reminder that in public health systems, there are known embraced components by prevention implementation sciences that dramatically affect the quality of the implementation outcomes. Tom Friedman writes about this in many of the publications he's done with the CDC. What's mostly true, what's true and mostly forgotten is that these components need to span the interactive systems framework, or that modified framework that Rohit Ramaswamy and his colleagues lifted up relative to governance, support, and delivery. We still need to be paying to all of these contexts at each of the levels in the prevention system. So it doesn't matter whether you're doing CTC, Prosper, which Dick Spoth and his colleagues have really put a ton of great work into, or Collective Impact, or any of these other coalition, community task forces, whatever the framework you're using, they are guided by a data-informed process. They build coalitions and they use backbones to support the infrastructure and so forth. But they all rely on these systems perspectives, these effective leadership strategies and perspectives, and being aware of the multiple layers in the system in order to ensure that they have the implementation infrastructure in place and the strategies that address each level of the implementation infrastructure. So the take-home points here: implementation has to be approached using this systems perspective. You have to design for the interconnections, not just the EBI itself. You have to design for the full support in the system, whether it's local, regional, state, or federal. Leadership underscores everything. It has to be adaptive, and it must include proactive and responsive strategies. It can't always just wait till the problems crop up and then they come in to rescue the implementation work. It really needs to be checking in, walking around, having informal conversations, being out in the community, being at each level of the support system. It's really critical that every one of those leadership responsibilities be addressed like a muscle. You're exercising it and you're doing it persistently. Organizations, leaders using self-regulation and reflective practices answer the question of, well, are we doing this well? What's going well? What do we need to sharpen? What are we missing in our toolbox? And what can we continue to bring? Remember that training is necessary but insufficient. It takes ongoing support, ongoing facilitation, ongoing strategy sharpening, ongoing use of data, feedback, and to build this sustainable infrastructure for your work. Our literature demonstrates that active implementation support and technical assistance, often through intermediaries, can significantly improve implementation outcomes. People get stuck. There are local politics, local conflicts. There's often issues that need more skill building, more capacity support. So this outside facilitation approach, as has been documented in things like CTC, Prosper, Collective Impact, and others, can really make the difference in helping move the needle in your implementation work. Lastly, implementation support. Remember, the goal is capacity building. You're really trying to build the pipes and the infrastructure that makes sure those pipes are well maintained, well designed, and that so when you turn on the spigot, the water flows exactly at the rate and the volume and gets to the destination you're trying to get it to. So that's the big goal in implementation, is ensuring that you've got the capacity and all the supports in place to make that happen well. I hope those take-home points are practical enough and they make sense for you. It's been a pleasure speaking to you about this, and I am now going to turn it over to Max Crowley from Penn State, who is remarkably smart about helping us understand and optimize value in prevention strategies and prevention science across the delivery of evidence-based interventions. So, Max.
Great. Thank you, everyone, and thank you so much for to all of the presenters as well as my colleagues in this session. As we've been thinking about what does extraordinary look like and how do we get to it? In particular, where I pick up the conversation is we've heard so far about prevention, about what evidence-based prevention can look like, the underpinning scientifically of that prevention work, as well as Will and Robin have really outlined, the the investment that needs to be made in both supporting implementation, building leadership, and overall thinking about systems transformation as we bring portfolios of prevention strategies that work across the lifespan, across domains to address these serious problems in our community. And so I have the pleasure of now thinking about, well, what happens if we get to extraordinary? What does value look like? How do we conceptualize it? But also, how does that value create virtuous cycles of where we reinvest over and over in our communities, in our works, in our efforts to build the systems that Robin and Will, for instance, have talked about? These are comprehensive efforts that really touch on so many different domains, so many different stakeholders, and they're built not overnight, but over time. And so in this sense, we make an investment now, and then we keep reinvesting in our communities. So briefly, I'm going to talk a little bit about what making sound investments in prevention, what that means, what that looks like, but also how we can think about value, as well as how prevention can save public resources. But it also, that investment then in turn leads to benefits across lifetimes, as well as that investment leads to benefits across different public systems, and how that has important implications for the stakeholders we engage and those that we bring to the table as we seek to build larger and larger coalitions and community efforts. So with that in mind, in particular, as we think about what does making sound investments in prevention look like, so as you've heard, in prevention science, we have increasingly studied the process of investing upstream strategies to avoid downstream costs. So there's actually a science not only of prevention, but a science of how we invest in prevention that has provided key insights into not only the benefits of prevention to the individual, but also to society and communities and the economy as a whole. And these are really important insights that build on what we've heard so far today and can inform the ways that we approach over time. And I've had the pleasure, as my colleagues have spoken today, to watch the different comments and questions that have come in. In particular, of course, this conversation around, well, what do we do when we're motivated to do this work, but we might not have all of the resources today to do it? What does that look like? How do we motivate those resources? How do we build? And I want to talk a little bit more about that. So there's key findings that can inform both our current and future work, and not only can increase the efficiency of what we do, whether it's public or through a private community context, but also save tax dollars and increase well-being for all. And so I'm going to touch a little bit on each of these important perspectives. So now as we conceptualize, so what is the value of investing in prevention? We've talked about, and we've heard about preventing before the onset occurs and before misuse happens. And the questions and comments, for instance, we've heard from some communities today who are seeing older individuals, young adults who are engaging. So where does prevention happen, and at what point in the stream of development does it happen to meet the needs of your community? Further, the value includes reducing, of course, the demand for drugs in the first place, as well as saving lives and breaking cycles, particularly when we see, for instance, intergenerational or historical community issues around substance misuse. But preventing downstream problems, too, can actually have a monetary value. And in looking at that monetary value, it's not the only value that we talk about, of course, but it often does provide a bit of a concrete metric of our benefits, and it can support sustainability as well as increase reach. And I'll talk a little bit more about that, about how we can motivate reinvestment, because when we invest in prevention, when we do it in an extraordinary way, there are opportunities to think about, well, maybe how do we recapture some of the cost aversion that we've created in addition to the lives that we save. So broadly, one of the things that we wanted to leave you with was this idea that prevention can save public resources, and that different prevention programs can have a combination of both what costs may look like or what resources are needed upfront, and then what happens in the future. So as you might expect, there's programs that have a cost now and they save in the future, but the scientific field has evaluated many programs, and some of those programs have a cost now, but they don't have future savings, right? They're not necessarily have been found to be effective. And there's actually also types of programs that, through building efficiencies, through thinking about the opportunities organizationally, can actually lead to savings over what is being done currently, as well as save in the future. As well, of course, there's things that could be somewhat more short-sighted and may appear to save now, but do not have that longer-term savings. And so, the reason that I want to kind of highlight this for you is we want to talk about and think about and encourage everyone to consider that there's a universe of programs out here. And so just briefly, what this figure indicates is there's literally hundreds of different programs, prevention programs, that have been evaluated in terms of what their costs are and what their benefits are, and they fall into those four categories. Now, as you might imagine, many of the programs where there's public estimates available are those that have a cost now but have savings in the future. But we've also identified some of those other categories of programs, and in particular, some of those programs that there isn't necessarily a savings now or a savings in the future, and it's important to consider them. But also that there's different levels of upfront costs that some of these programs require, as well as downstream benefits, and that there's a lot of opportunity to tailor to the needs of your communities, tailor to the needs of your different stakeholders. So with that kind of more abstract thought in mind, what we really want to do is now drill down and talk about, well, what is, for instance, some of the work that we want to do? Where does the prevention work actually come in? So for instance, we know, for instance, there are different types of family therapy and family therapy approaches, and Denny talked earlier about, for instance, CBT, that sometimes those investments are costly, right, upfront. So for instance, here we have an example of functional family therapy, but there's also this positive benefit, not only as we found on the children, on the parents that are involved, on the ability to keep, for instance, youth out of juvenile detention centers by reducing substance misuse, but also that there's a savings to the taxpayer. So there's a savings, as indicated here, of, for instance, while there may be a $3,500 investment in the kid and their family, there may be, many thousands of dollars from reduced crime, reduce healthcare costs, as well as increase participation in the labor market, which of course leads to increased earnings. But there's also, for instance, some of these programs that we've identified, for instance, such as the classic straight program, where there is a bit of a cost up front, but there also is not savings, and there actually is cost to the taxpayers in the future. And this is the importance of using evidence-based strategies, as we've heard throughout the session today, in really thinking about, well, what are we investing in? And sometimes the things that may look good, or we may have certain stakeholders in our communities really advocating for, are not the ones that are actually going to serve our community, but they're also not going to bring value to the community. And we really want folks to kind of have the opportunity to think about their portfolio of different strategies across the board and what it means to make an investment and what it means to actually achieve value. So with that in mind, we wanted to talk about and share with folks that when we talk about prevention, when we talk about building these implementation systems, when we talk about the support and work that goes into that what we're seeking to do is actually achieve economic benefits that accrue across lifetimes. Right. So there's that initial investment, as we've pointed out, but over time, as individuals, whether they're youth, whether they're young adults, whether they're adults, but as they continue to age, what we see consistently is that there are these benefits that accrue from reductions in criminal justice system utilization, reductions from healthcare utilization, reductions in need for means-tested programs, because the underlying issue of substance misuse has been specifically addressed, right? And so we often bring to prevention, as Denny talked about so artfully at the beginning, that there is this upstream investment to prevent downstream problems, but some of those downstream problems include the cost that it takes to serve and support these individuals once they've already got a problem in hand. Further, that when we make investments, that different types of prevention, different types of evidence-based programs achieve, from a fiscal standpoint, achieve value more or less quickly, for instance. So I mentioned functional family therapy. So for instance, therapies that are near to the problem, we see a very short timeline before, as we saw on this slide, that there's a point where the cost is overcome by the benefits. So, for instance, with functional family therapy, with other programs like school-based programs like the Good Behavior Game or life skills training, we see in a similar context that over time, there is that break even, that time until that investment begins to pay off. Further, as I mentioned before, that when we make investments, strategic investments in prevention, and when we do so in an extraordinary fashion, that the economic benefits in particular are across systems. And this is really important as we start to think about the stakeholders that we engage with and that we involve. So investing in prevention may, of course, brings the usual stakeholders to the table, for instance, in our space, those in the criminal justice system, but also highlights the opportunity to bring those that may not be, for instance, as proximal to some of our existing efforts, those in healthcare, those across other government services, those in education, the opportunities to grow those stakeholder partnerships, because there's actually not only value to the individuals that they serve, but value to the systems themselves through reduced need for high cost, expensive services, as well as potential benefits because those individuals are better able to be part of those communities. So Robin mentioned, for instance, one particular approach for how we build not only individual program delivery, the delivery of a singular program, but how do we actually build coalitions? How do we build teams and stakeholder groups, as many of you are already doing? And one of those, for instance, is the PROSPER program, or the PROSPER system in particular. And that includes, for instance, has been used to support the delivery of universal school and family-based prevention programs, primary prevention, as Denny described them earlier today, and where they seek to support in particular core skills and competencies, and as well as engaging with parents and families during that key adolescent period that Denny brought such important neuroscience evidence around the malleability and opportunity of that time. So, for instance, we've seen within where we're not only evaluating a single program, but we're evaluating the system itself, just like we would, for instance, evaluating a pharmaceutical, evaluating communities, where we're actually taking empirical evidence, experimental evidence, and looking at how these systems that Robin spoke about earlier, and engaging with them and supporting those communities to use them, and then following the benefits not only to the individuals that are served, but the communities across time. And so one of the things that we've seen as part of the economic evaluation looking at not only the individual outcomes, but the overall fiscal or economic benefit, is that, as described earlier, we see those benefits accrue across systems, not only to the criminal justice system for preventing substance misuse. In this case, PROSPER, for instance, has shown impact on a number of different substances that are misused, but in particular, preventing misuse of opioids, and seeing that the benefits from that delivery of those services map onto and are averted from the criminal justice system, from healthcare costs, and directly from Medicaid. And the importance and value and opportunity of that really can't be discounted. So with all of these different components in mind, what we really want to leave you with today, before Denny closes out the session, is thinking about, what does value mean to your community? And does the economic value, in addition to the larger value that's created, have a role in your decision making? And if it does, how does that motivate or assist in your decision making around making the investment in these upfront costs that it requires to not only deliver prevention, evidence-based prevention programs, but to do so in an extraordinary fashion, as many communities are already seeking to do. And once you've made that investment, who are the stakeholders that can be brought to the table? Because the value flows not only to the individual, but to the systems that are being served. And how does that grow and expand who you engage with and what context that you engage with, and potentially bring not only more resources to the table, but the social capital and the leadership within the communities that you need to grow and reach that point of extraordinary work. So those in particular, combined with considering that ultimately it is an investment, prevention, as you've heard today, can be something that results in extraordinary benefits backed by excellent and strong science, but it does require that investment. And how do we support communities such as yours in growing in a sustainable fashion that leads to a comprehensive prevention effort? Thank you.
Denny, would you like to give some concluding remarks? Denny, would you like to give some concluding remarks?
Oh, I'm sorry.
Okay.
That would automatically come on because I heard it was movement sensitive. So hi, yes, thank you all for your talks. They were amazing. I had no less of an expectation. For anybody who doesn't know, everybody calls me Denny, so that's why I have an alias here. Let me get my slides here. Yeah, so these are not actually my last slides, so I don't know what happened to them, but that's okay. There we go. Okay. So all of these are outcomes of prevention science. As we have indicated, these are, disrupting pathways, normalizing trajectories for disadvantaged populations, equalizing the playing field, et cetera. You could see it. The first four are really about, more or less downstream approaches, and the last four are really about upstream approaches. And we know so much now, and what is really important and what has become really apparent by these different presentations is that we're ready to roll. We have a lot of knowledge that needs to be applied very systematically, that needs to be institutionalized, but we also need to pay a lot of attention to how they're implemented. We talk a lot, and I'm seeing, in the chats, I'm seeing a lot of attention to co-creation and collaboration with communities, and nothing could be more important. Everything has to be considered in a specific context. So we can't just jump into it and say, we have all these interventions, we can change the world, we can redirect trajectories. We really have to pay very close attention to the details of how they're being implemented, and that we're not imposing ourselves in communities, but rather we're co-creating this process and considering every specific context. We often adapt interventions that have been used elsewhere for any given specific context. And sometimes they work when we put them into a new context. with some adaptations, but sometimes they can be extensively adapted and still will not work in that new context. And we really need to start from scratch. And so I think Robin and Will really provided a lot of guidance in that respect, with respect to considering all the contextual interactions that need to be considered in these complex systems across communities that are going to differ quite a bit. So they've given us a lot of overarching guidance. And then Max brought to the fore that an economic analysis it provides a powerful tool for assessing needs and evaluating effectiveness, comparing interventions, and then comparing them with treatment so that we can show the extent to which these upstream processes can really be produce much more value added and be more economical in the long run. So, we're really talking about whether prevention is worth a pound of cure, and it is. And I thank all of the speakers for that. So Laura, back to you.
Thank you, Dr. Fishbein. I wanted to open it up to all of you again because we have a few minutes left, and I know that in our discussions you were very open to answering questions. And over the course of your workshop, we actually have had several questions come in, many of which you have answered very quickly by yourself. And I'm wondering if maybe any of you would like to, we've still got a few that are available and unanswered, and there may be a reason that you're holding those. So I wanted to kind of turn the tide and hand it back to you to ask if any of you would like to specifically address. We can start with this first question here. Is there a list of researched programs for prevention? And this is a very popular question. Where can people access a list of the evidence out there?
I can address that. There are a number of registries that exist. Blueprints is one. What Works is another. The WISIP. So I know I'm giving you a lot of acronyms, but if anybody needs to contact me, that's fine. But there are registries out there that not only list the evidence-based interventions, but they're listed by domain and types of populations that they work for best. And they also give you a lot of the research evidence that suggests that they are evidence-based and they're rated. They have evidence-based and various levels. Some are still promising and haven't been fully evaluated yet. Some work for different populations or different domains of interest. So there are a lot of registries out, several, let me not say a lot, there are several registries out there that have lists of evidence-based interventions.
Wonderful, thank you. Another question that has come up relates to these domains of primary, secondary, and tertiary prevention. And this audience member asks, what about prevention in the sense of preventing relapse or working with those needing restorative justice? Isn't that also prevention? And what about the next generation? What about their children?
I'll say something really quick and then I'd like to hand it over, just that that there are, so I see prevention at every level, and we're discriminating between primary prevention and secondary and tertiary and so forth. But if you treat somebody, you're preventing relapse, you're preventing recidivism, you're preventing escalation, you're preventing problems in the home with family and children and so forth. So I see prevention everywhere. Maybe that's just the lens that I'm looking out of, but they all have preventative effects, but at different points in that river or that stream where we can make an impact. And as for intergenerational effects, absolutely, that occurs at the social level, and it also occurs at the biological level, at the epigenetic level, where we have transmission of protection, if you will, across multiple generations through ways in which genes are activated. So that's another story, but it can have multiple effects on subsequent generations.
Thank you. We've had a couple of administrative questions come in that I can address very quickly. For those of you interested in downloading the slides, you can access all of the slides from our presenters today under the Event Resources tab, which is really an arrow down on the bottom left-hand corner of your screen. If you click on that arrow, a variety of resources will be made available. One of them is titled Slides, and you can access the slides that way. Another question that has come in was regarding the registries that you just mentioned, Dr. Fishbein. I'm wondering if you would mind typing those into the Q&A box for us, and we will be happy to upload those on a document for those of you to access. We also can send those out in an email. Okay, the next question is more of a technical one. What is the difference between an evidence-based practice versus an evidence-informed and/or culturally aware practice?
I'm happy to. We'll all jump in at the same time, awaiting. I'll take a first cut, but welcome my colleagues and partners to offer some too. Typically, evidence-based program is one that has been studied in randomized controlled trials. There are different standards and definitions which have been published recommending different thresholds or bars for how many trials and different authors and different populations. But the common denominator there is some randomized controlled trials, some number of them. Evidence-informed typically has not been through that level of rigorous testing, but is building from components or strategies that are known to be active ingredients themselves. And so while they may be putting together those components or ingredients in a new way or in an innovative way, perhaps to be responsive to a particular challenge or question, they do have some evidence in how they were built, even if the program or intervention itself has not been holistically trialed. Culturally aware, it depends on where the question's intent with that, but I might suggest that culturally aware program would be one that has baked into its program or process attention to cultural values, preferences, strategies that may be particularly important in implementation, whether that is because the program or practice was designed for a particular population or community, or because it has generally baked those in for adaptation and delivery to many different types of communities or populations. So that's what I would offer for those. And to me, again, this all gets back to, there was a question earlier about program adaptation and the importance of the co-creation process. We really have come to understand and really expect that no matter if you are starting with an evidence-based program or an evidence-informed program or something else that you're transferring into a new setting, it is likely going to be adapted, whether you would intend for that to happen or not. And so being aware that that's a reality and paying attention to and monitoring core ingredients, outcomes, and involving key stakeholders is really important.
I think, too, I wonder, Laura, if I could just add, there was a question in the chat some time ago around EVIs, EVPs that were developed in the dominant culture. And I think that's a really salient, important conversation to have, and it relates to this particular question as well. Clearly, all science, but especially prevention science, needs to spend as much time continuing to grow to its evidence base around how to rethink its research methods, the ways that it generates rigor across different cultures and across different contexts. So the traditional way of generating evidence is fraught with many of the questions that people have lifted up around, equity and the dominant culture and so forth. And I think we're aware of it. I know we talk about it a lot, and I think that the science owes it to the people that are depending on it to figure out ways to adapt the science to take those issues into account. So I just didn't want to let that question go without, lifting it up and acknowledging it as a really important and central conversation in prevention science these days.
Fantastic. Thank you, Dr. Jenkins. The next question is going to go to Dr. Crowley. Is there a set formula to show cost savings for prevention based on the amount of funding put towards prevention and spent on treatment in a set county? Perhaps an algorithm we could plug tailored numbers into? Does such a thing exist, Dr. Crowley?
So it's a great question, and I think that there's actually some great solutions out there. So Denny mentioned this briefly in the context of the registries question, but I highly recommend those who are interested taking a look at the Washington State Institute for Public Policy's website, as well as the Pew Results First website. So both are pretty easy to search, and we can, of course, make the links available. But both provide really valuable information that's not only at the general level for prevention, but actually tailored to a variety of different programs. Another question actually asked where for instance, data on functional family therapies and scared straight came from. That actually came from the Washington State Institute for Public Policy. So a really great resource that gives you more than just a general number, but actually allows you to look at portfolios of programs and what those look like side by side, their costs, their benefits, as well as the information about the difficulty, for instance, of implementation. So a lot of great resources that are out there. And, that's really one of the core messages I think we wanted folks to take from today, is that you really can start thinking about when you reach and strive for the extraordinary in this space, the opportunity of making an investment and actually reaping a return from it that benefits both those you serve, but your larger community and the larger kind of economic considerations as well. So thank you.
Thank you, Dr. Crowley. And I've just been made aware that the document that contains the slides under the Event Resources tab is titled NPSC for National Prevention Science Coalition. You need to click on the downward arrow and scroll all the way down. There are 5 or 6 items there for you to choose from to download. Okay. The next question we've got here is, are there evidence-based programs for warm handoff programs? Anything in that field?
Well, I'll jump in, but just with a short answer. I think, evidence-informed, things like system of care, and some of the comprehensive case management programs, which are mapped back to various assessment tools which identify needs and service arrays that folks who are in those vulnerable positions could benefit from, that are informed by that lived experience, that cultural, there are those kind, that's what system of care was developed to do, was to integrate those case management and those core functions for those kinds of practices. But it would be more, it'd be interesting to hear more about what you're thinking about relative to a warm handoff, whether it's the actual facilitation of the connection in the service array or some sort of competency among the workforce itself. I'm kind of curious about the term.
Okay, yeah, that's all we had listed for the question right now. So if we get any more information on that, I will share it with you. Okay, and we've also had a comment come in that the CDC has a manual on evidence-based programs, including their names, that also could be helpful for that topic and many others. We've had one audience member ask what the source was for the Preventing Youth Incarceration information.
Yep, thank you. So that's actually, as I mentioned before, the Washington State Institute for Public Policy. So Washington State Institute for Public Policy, sometimes colloquially called WISIP, and that's what Denny was referring to earlier. And so if you go to that website, you'll see on the website the functional family therapies listed under there, and that will provide you with not only the source, but also additional resources for more information if you're interested.
Okay. Great. And we did have a follow-up response to that question, Dr. Jenkins. It was really looking and having this understanding that a lot of grants are requesting, if you are operating a grant-funded program, they are requesting that you use an evidence-based practice. So she was curious around any best practices that might be available for warm handoffs.
Actually, I'd have to do some research about that. I don't have a clear answer about that. It depends on the population she's referring to and the system that she's in and the nature of the kind of services that they're trying to broker. So it's a great question. I'd like to learn more about what the particular need is.
Okay.
And I do know of some work, for instance, in the hub and spoke space, particularly around opioid efforts, where there have been some efforts to move towards evidence-informed and evidence-based practices. So really trying to build the evidence in that space, because as many are aware, it's a newer domain. And so it's really important. I've seen a number of questions about, in terms of grantsmanship, the implications of evidence-based programs. And so understanding what the specific funder actually wants in terms of evidence-based practice is really important. Sometimes they will have their own list of what evidence-based practices are. Sometimes they will have a general standard or a criterion of evidence. And that's also, something that, they may want to, for instance, to see an experiment having been done with it, or sometimes that isn't as important. So sometimes it requires, a bit of fluency around understanding what the funder wants and then working backwards from there. And so to the point of the original question, there are some evidence-informed practices, but evidence-based practices, specifically in the warm handoff space, as far as at least we understand it so far today, are much more scarce. So if you're having trouble locating them, you're probably not alone.
And
okay.
If I might just, for a follow-up comment, just I see a number coming about evidence and looking for the evidence-based programs, and I think this is great. And one of the things that hopefully you've picked up through some of the implementation is, evidence is a good starting point. It is a necessary starting point. It really helps us determine what programs, practices, policies we might adopt. But as you saw from some of the slides we presented, evidence-based program or practice does not necessarily guarantee that you will get to outcomes. One of our colleagues in the field, David Chambers, wrote a great paper and really posited that evidence-based programs or research trials are the foundation of knowledge. That's where the evidence starts. But evidence can only be optimized only when it's in context, in your context. And the importance of having ongoing quality and outcome monitoring systems, data systems there in your local communities and organizations to ensure that you're reaching outcomes and to be able to have a bit of a data dashboard to make real-time adjustments and shifts in your implementation processes. That is really a key piece to getting to outcomes and getting to sustainable outcomes. So I just wanted to make sure to put that plug out there.
Excellent. Thank you. You're making me think about extraordinary really can look different in every community. And so that particular comment, I think, is a beautiful way to end the entire workshop on how one person, how one organization, how one community can effectively move that needle closer towards extraordinary for themselves in their own unique situation, and the variety of resources, and more importantly, the ways of thinking about this that you all presented today, we will cherish. Priceless. Thank you for that. We have up here now a slide, the same slide. We're coming full circle to our reflection for today. And we've got 5 minutes left. Just want you all to take a minute and really think through application of all of the fundamentals you've just explored with the National Prevention Science Coalition as you think through these questions. And in particular, number one is focused on the various dimensions and variables you might want to lean into a little bit more. But number two is that question, you know, if you implement something different or make a change in some way, shape, or form today, and you come back 2 to 3 years from today and you give it a close look, right? What's going to demonstrate for you that effectiveness? What's going to visibly demonstrate that effectiveness? And if you really think through that, you're going to naturally start thinking through those outcomes and those outputs, as well as the multiple other dimensions that all of our presenters reviewed today. Thank you, National Prevention Science Coalition. What a pleasure. Been very dynamic. We appreciate it.
Pleasure was ours.
Thank you.
Absolutely.
All right, at this time, we are going to pause for our final break of the day. But I did want to just mention that we have a star lineup of representatives from the CDC, SAMHSA, Prevention Technology and Transfer Centers as a part of SAMHSA, CADCA, Drug-Free Coalitions, and the DEA, all coming back to join us for our final panel, which is a resource panel, and we'll kind of round out the day by serving you with a multitude of resources, as if we haven't heard of enough today, right? It's been quite a wonderful summit where the resources seem endless. You know, a lot has been developed, and so that's not lost on us. So please join us back at 3:15, and we'll see you at that time. Thank you.